yang akan disampaikan oleh Dr. T. Tulip. Dr. T. Tulip is our new chemical pathologist in Hospital Seberang Jaya. So topik yang akan dibincangkan adalah update on congenital hypothyroidism screening program from the laboratory perspective. So there are a few changes based on the latest guideline published on last year regarding the screening and monitoring of baby throughout congenital hypothyroidism. So kita akan bincang daripada perspektif laboratory dan there are few changes yang saya harap semua daripada hospital dan klinik kesihatan dapat ambil maklum mengenai changes yang kita akan buat probably by next week. Okay, terima kasih, dipersilakan Dr. T. Tulip. Dan lepas ni saya akan letakkan borang kehadiran, boleh isi borang kehadiran dekat message. Terima kasih.
Selamat pagi semua. Nama saya Tulip. Saya seperti yang diberitahu oleh Dr. Jam, saya pakar patologi baru di Hospital Seberang Jaya. So, tanpa membuang masa pagi ini, saya akan memulakan CME saya pagi ini. Izinkan saya bercakap dalam bahasa Inggeris. So, good morning once again to all of you. Thank you for coming. So today I will speak on give a short update on our current congenital hypothyroidism screening program and from the laboratory aspect. So this is the outline of my presentation. So just a brief overview of congenital hypothyroidism. Then I'll present some data. Then also a brief introduction on congenital hypothyroidism screening under our Ministry of Health. Then I will let all of you know disorder with the deficiency of thyroid hormone present usually at birth. So the incidence is worldwide is 1 in 2,000 to 4,000 live birth. But in Malaysia, the reported incidence range from about 1,000 to 3,000 plus live birth. And is one of the most common preventable causes of intellectual disability worldwide. So why we need an early detection and a screening program is because when you start the treatment early, there's due to the inverse relationship between the age at treatment initiation and IQ later in life. So if you delay the treatment, the lower the IQ of the baby, of the affected baby. So again, another reason for the screening is because there's few or no clinical manifestation in the newborn baby. And there's also the cases are sporadic, meaning that we are impossible to predict which infant are likely to be affected. So this is the physiology of the thyroid hormone production. So basically, our thyroid hormone is, of course, from our thyroid gland. So it's under the stimulus of this thyroid stimulating hormone secreted from the pituitary gland. So with the stimulation of TSH, our thyroid hormone our thyroid gland will produce T4, And this all the and then this T4 as well as a T3, but the majority of the T3 is a result of peripheral conversion from the T4. And when your thyroxine and your T3 at certain level, when it's adequate, then you send a negative signal to the pituitary as well as the hypothalamus. This is what we call the negative feedback. And this related to how we interpret the thyroid function test. So in a straightforward case, when there's a very high T4 or usually T4, T3, then the TSH will be suppressed. And on the other hand, when the T4, T3 is very low, then that's why we see the TSH. In a clear-cut case, the TSH will be more than, our lab report we put at more than 100. So these are some of the etiology of congenital hypothyroidism. So the first one is a thyroid dysgenesis. So this, as you can interpret from the word, it simply means the thyroid gland is probably not well formed or dysfunction. So in this group of patients, generally they will have a high level of called TSH. The second causes is called dysharmonogenesis. So in this case, the thyroid gland is formed, but there's a problem with its production. So as stated here, normally formed thyroid gland, but its function is abnormal. So in this type of case, the cord TSH can be either normal or borderline, and they can present later with mild symptom. And then the next group is a transient hypothyroidism. For this group of patients, they can have a delayed rise in TSH level with cord TSH within the reference range. And the causes can be iodine deficiency, or when you have higher than normal iodine exposure, you can also have a transient hypothyroidism. Other causes are maternal blocking antibody or the mother taking the anti-thyroid drug. I think the few cases we have, they are due to the maternal factor, the last two factors. This is a more comprehensive causes, just for your information. So how the history of this screening in Malaysia. So it's actually initiated in early 1998. So with the TSH level measured from the cord blood. So the nationwide program started from 2003 onwards. And patient with the high, based on our agree flow chart. So when there's high TSH and the low cord, the patient will be notified and to come for recall, so that a venous blood can be taken. And in the latest, it's suggested to be ideally between day 4 to day 6 of life. So the latest guidance is from this consensus guideline on screening, diagnosis, and management of congenital hypothyroidism. This is published by the Malaysian Endocrine and Metabolic Society. So one of their aim is to standardize the practice so that in the future we can have sufficient data pool to develop our own local reference range for thyroid function tests. Because at the moment we are quite dependent on the data from from the manufacturer or other perform on the non-local population. And this guideline also has specific guidance on this few group of patients. So the sick neonate, the preterm, low birth weight, infant, Down syndrome, multiple birth, and prolonged jaundice. So how do we come to the determination of the TSH cutoff value? So go back to the history. It's actually there was a formation of working group consists of a chemical pathologist and science officer. They were under the National Pathology Service in the year 2014, because we have different analyzer used in different state, so that from this study they have done a data collection from all the state hospital and selected district hospital. So with the inclusion, inclusion exclusion criteria, they will include all results except TSH equal more than 60 and also suppress TSH. So the total data analyzed about 41,000. So they got the value of got TSH in between the lowest 0.11 to 57.77. So they have done the calculation and determined that the 97.5 percentile to be 20 milliIU per liter. Okay, this is what is extracted from the current guideline. So you will have newborn baby will have a got TSH. So we will run at this level we will run the TSH. So they will group into 3 groups. If the level less than 20, so we won't do any notification. There's no further action from the clinical side. But when the level is more than 20 or more, then we have to do a COT free T4. So from this flow chart, if the free T4 COT free T4 is more than 15, then again there's no further action. But however, when it's equal or less than 15, then they have to be recalled for venous thyroid function test. And this group is more clear cut. They have high level, so they will be recalled for the evaluation and venous thyroid function test. And at this stage, the clinician they might consider treatment. So this is during the recall. So for those with got TSH more than 20, equal more than 20, and also low free T4. So the blood will be venous blood will be taken and analyzed. So if the baby TSH is less than 6, no further action. And for intermediate case 60 to 20, in this latest guideline, they recommend to reassess in 1 to 2 weeks time. So depending on the level, they will either treat or continue the observation with the discussion with the parents. For cases when the venous TSH is between 20 to 40, so we will look at the free T4 level. If it's more than 12, then they have to again be repeat. And depending on the trend, they might be treated or continue observation or consultation with the pediatric endocrinologist. But if the level less than 12, they have to start treatment. And clear-cut case TSH is very much elevated, then they have to treat. This is some of the data. For this one is mainly on COT TSH and free T4. So it's a combined hospital Seberang, Jaya, and hospital Pulau Pinang from January to June 2022. So we have around 5,792 COT TSH received. So for out of these 5,792, 86 we have to perform a reflex COT free T4 because the COT TSH level is equal more than 20. And this and out of these 21 of them, they actually have a COT free T4 level equal or less than 15. So they definitely, this group have to, according to the, if based on the latest guidance, they have to be recalled for venous sampling on day 4 to day 6. Because when you look at the record, there will be more venous TFT performed, because some they actually are being investigated for prolonged jaundice workup. So this is the the number of sample being rejected, the venous thyroid function test. This one is from July last year until June this year. So the most common cause are these two, either insufficient sample or the sample being repeated. They are being repeated in a very short, like within, some are like 2 samples in one day, or usually less than 3 days from the record we collected. So the rejection rate generally is less than 1%. So this is what being discussed in last week. So first is we will implement this consensus guideline on screening, diagnosis, and management of congenital hypothyroidism in Penang State. And this guideline can be downloaded from the website. So one of the major changes is, previously we used the manufacturer reference range. So for the TSH, we categorize day 0 to day 5, and then another category is 7 to 30 days. However, with the implementation of this guideline, we slot in this one more group. It's a day 4 to day 6. So for their level, their TSH should be less than 6. And then 3T4, the reference rate will be 13 to 28. So any case with the TSH more than 6, we should notify. And they should be monitored again for repeat venous thyroid function test. Other thing is regarding the critical result notification. So we will still continue to notify if the cord TSH value equal or more than 20 milli IU per liter, irrespective of the cord 3T4 value. So that meaning that we will still call the clinical site to inform them regarding this result. Another thing for your knowledge, so our system iLab is one limitation when applied to the neonatal, the baby, because it can only capture the day of life. So example, when maybe the baby was born 11 p.m., but in the system it will become day 2 of life after midnight, versus a baby born at 1 a.m., they only become day 2 after 23 hours of life. So this will have some impact on the reference interval use. That's why we have to be cautious of interpretation those day 3, between day 3, day 4. Right. Then for venous TFT received within, if it's confirmed to be taken within 72 hours of life, we will have a sample rejected as a TSH taken at this period is subject to the physiological TSH surge in the newborn. So this is due to the stress of delivery and exposure to the cold environment of the extrauterine environment. So other thing that we hope, before you sending any sample, to ensure there's a day of birth written, and if possible, if there's time of delivery, even better, so that we can have a correct reference interval use. And we'll allow a retesting of venous thyroid function test in 1 to 2 weeks time, so as stipulated in the consensus guideline. This is to allow the clinician to have a better, so that they can observe the trend in the both TSH and the 3T4. Okay, so this is already mentioned. And for the reporting of cord TSH, previously we report as round figure, but we will change it to 2 decimal point of reporting. So you'll receive maybe like 5.89, something like that. So some message is there'll be some increment in the number of requests for venous thyroid function tests in the future, and we will, to try to reduce the rejection of neonatal sample, so that have to ensure the sufficient volume, and also regarding the retesting period, we have to communicate with the clinician or requester when in doubt. So from the audience, if you have any question or suggestion, you can ask now or later. So these are the reference. So with that, I'll stop my presentation. Thank you very much.
Okay, ada apa-apa soalan atau komen atau any concern regarding some changes in our reporting after this? So kalau tak ada, saya just nak recap balik sebelum kita dismiss. Yang pertama adalah according to the new consensus, the repeated venous blood selepas any abnormal of cord thesis adalah pada day 4 to day 6. So the day 4 to day 6 is quite critical before the decision can be made. Sama ada patient require treatment or not, or patient can be diagnosed as congenital hypothyroidism. Sebab kalau congenital hypothyroidism, treatment should be initiated within dalam tempoh 14 hari selepas kelahiran. Jadi kita nak elakkan daripada the baby can get the overt congenital hypo ataupun dapat mental retardation ataupun cretinism. Jadi kita sebagai laboratory personnel mesti faham benda ni, terutama bila ada sampel mesti uruskan dengan betul. Dan yang kedua, kalau ada notification, maksudnya kepada hospital ataupun klinik kesihatan, kadang-kadang kita tak dapat access to the doctor, requested doctor, we will inform to the lab. So lab must take action, maksudnya kena pastikan keputusan itu diberitahu dan dalam masa yang sama tindakan yang sewajarnya perlu diambil lah. So maksudnya notifikasi sama ada notifikasi congenital hypothyroidism screening cord blood ataupun notifikasi berkaitan darah yang diambil pada hari ke-4 dan ke-6. So kalau darah yang ambil pada hari ke-4 dan ke-6 kalau sangat abnormal melebihi 20 mili air per liter, kita akan buat notifikasi juga. So yang ni sangat penting lah. Sama juga untuk rejection. Kalau mana-mana rejection, maksudnya sampel perlu diulang dan perlu buat pengulangan tu dengan sebetulnya. Maksudnya in the laboratory, from the laboratory perspective, kena pastikan notifikasi tu dibuat pada masa yang sepatutnya lah, secepat mungkin. Dan yang kita ambil maklum juga adalah berkaitan tentang date of birth. So sekarang ni saya nampak banyak juga, dah banyak yang letak date of birth, tapi kalau maksudnya from the laboratory referring, maksudnya kalau you tengok situ tak ada date of birth, so we request that it's possible you do the verification first from the doctor. So that instead of this HPP ataupun Seberang Jaya terpaksa call, we hope that the respective KK ataupun hospital dapatkan maklumat the date of birth tu. Sebab yang ni yang kita akan masukkan ke dalam laboratory information system. Kalau date of birth tak ada, secara automatik our LIS akan letak the reference tu kepada adult reference. Lower to more than 6. Previously kita ambil sampai 11. So yang tu ada sikit perbezaan dan we expecting they're going to be more sample to be repeated. Tapi yang tu adalah mengikut konsensus ataupun guideline. Dan isu yang terakhir adalah berkaitan tentang sampel sampel sufficient ataupun tak. Ini memang ada di-discuss dalam our meeting with clinician, pediatrician, FMS dan juga pathology mana berkaitan tentang sample insufficient. So tapi berdasarkan data yang kita extract for the past 1 year, memang our rejection rate for the thyroid function test is less than 1% lah. Memang ada tapi tak terlalu banyak dan hopefully dengan test tube yang kita buat sekarang ni mencukupi lah. Tapi sometimes because the test tube is according to the cellularity of the sample itself. Kalau cellularity of the sample tu banyak, then probably the plasma yang kita use tu akan kurang, dan means kalau ada dengan test yang lain termasuk liver function test dan thyroid function test, then probably some of the analyte unable to be analysed lah. Okay, saya rasa itu saja untuk kita nak tekankan pada hari ini, dan kita juga akan issue surat to all the hospital and klinik kesihatan tentang perubahan ini. Ada soalan lagi sebelum kita tamat discussion pagi ni? So kalau tak ada apa, kita boleh tamatkan CME pagi ni, dan kalau ada question, always can ask me or any of the sign officer ataupun ada pathologist as well. Okay, terima kasih. Assalamualaikum. Salam sejahtera.